Entacapone, known by the drug name Comtan, is a medication that is used in the treatment of Parkinson's disease. It must be used in conjunction with medications like levodopa or even a levodopa-carbidopa mix to play a role in Parkinson's treatment. In other words, entacapone has no effect on Parkinson's signs or symptoms on its own. This fact can be explained by the medication's mechanism of action, which I will touch on shortly. However, to understand entacapone's role, we must first understand Parkinson's disease. Many aspects of the disease are poorly understood. However, Parkinson's symptoms are believed to arise from damage to the substantia nigra of the basal ganglia, which is a section of the midbrain responsible for contributing to the extrapyramidal motor pathway. This pathway is responsible for regulating voluntary movement. As such, it has direct connections with the motor cortex and influence on expressed movements. The pathways of the basal ganglia are quite complex, but I think the most important thing to understand is that dopamine produced by the substantia nigra plays a very important role. In healthy individuals, dopamine can essentially be viewed as WD-40, and the rest of the basal ganglia system can be viewed as a locked gate preventing movement. Dopamine works by binding to both D1 and D2 receptors. When dopamine binds to D2 receptors on the GABAergic neurons, it inhibits those neurons from releasing inhibitory GABA, preventing the complete closing of the gate, or in other words, dopamine prevents the complete blockage of movement. When dopamine binds to D1 receptors, it functions to loosen the gate further upon stimulation from the motor cortex, allowing for movement to more readily occur. In both instances, dopamine prevents the basal ganglia from stopping all movement, acting as WD-40 on a rusty gate. So when there is damage to the substantia nigra, such as occurs in Parkinson's, there is not enough dopamine released to help keep the gate open and allow for smooth, voluntary motion, resulting in tremors, rigidity, akinesia, and postural instability, all characteristics of the disease. Simply, there is an overall limit on motion without dopamine. Therefore, the goal of treating Parkinson's disease has traditionally been to increase dopamine levels in the striatum of the brain. Dopamine cannot be used itself because of the blood-brain barrier, which prevents dopamine from entering the brain tissue. Instead, L-dopa or levodopa is used. Levodopa is a precursor to dopamine that can cross the blood-brain barrier. In the brain, remaining neurons from the substantia nigra and in other regions decarboxylate levodopa to form larger dopamine stores, increasing dopamine's presence in the basal ganglia system, which can abate some of Parkinson's symptoms. Now, unfortunately, when taken alone, levodopa has a very small bioavailability, with only about 2% of the drug actually reaching the brain. This is because of the breakdown of levodopa can occur both in the periphery and in the central nervous system. In the periphery, levodopa can be decarboxylated into dopamine, preventing it from crossing the blood-brain barrier. It can also be broken down by Comtan, an enzyme that breaks down catecholamines such as dopamine, its derivatives, norepinephrine, and epinephrine. The metabolism of levodopa may result in the rapid reduction of the drug to below therapeutic levels throughout the course of the day, creating what are known as off times in which Parkinsonian symptoms reappear. In the past, this has been combated by increasing the dosage of levodopa. However, this can result in the oversaturation of the basal ganglia, resulting in symptoms on the other side of the spectrum, which are loose and unregulated by the basal ganglia entirely, known as dyskinesia. So in an effort to increase levodopa's bioavailability and combat these problems, a few drugs have been created, one being entacapone. Entacapone is a Comtan inhibitor. By blocking Comtan, entacapone prevents levodopa's breakdown in the periphery, increasing levodopa's bioavailability to the central nervous system. Entacapone has shown to both prevent off times, in which Parkinson's symptoms return throughout the day, and to allow for lower doses of levodopa, preventing the overload and severe dyskinesia. It can be viewed as a medication that allows for greater therapeutic control of levodopa and therefore Parkinsonian symptoms. Now to get into the specifics of the drug. Entacapone can be administered orally with levodopa up to 8 times a day. The individual dose is typically 200 milligrams. Side effects may include dizziness, nausea, dry mouth, diarrhea, upset stomach, yellow-orange discoloration of the urine, and orthostatic hypotension. Other major adverse effects are falling asleep suddenly, severe dehydration, severe vomiting, diarrhea, and increased sweating. Some of these effects may be caused by alterations in electrolyte balance. The nurse should instruct the patient to call their provider with the onset of any of these adverse effects. The nurse should also monitor Parkinson's symptoms in the patient, as the goal of entacapone is to reduce fluctuations. The nurse may also want to examine a list of medications taken by the patient, as entacapone can prevent the metabolism of drugs such as methyldopa and dobutamine. In addition, the nurse should advise the patient to increase water consumption to prevent severe dehydration. They should inform the patient of the potential dangers of the drug that may warrant not operating heavy machinery or accomplishing other dangerous tasks until the patient knows how the drug affects them. Lastly, according to the FDA, entacapone is in the pregnancy category C, meaning that teratogenic effects have been found in animal studies. Entacapone should only be used during pregnancy if the benefits outweigh the risks.